Progression-free survival, or PFS, was the primary endpoint in the MAVORIC trial. It is an endpoint that's commonly used in clinical trials of anti-cancer therapeutics. In MAVORIC, PFS was defined as the time for randomization until documented progression or death, so it incorporates both survival and control of the disease. This endpoint is particularly meaningful for an incurable disease like mycosis fungoides or Sézary syndrome. PFS can help me to describe to my patients how long they might expect to respond to treatment without progressing. For diseases like MF or Sézary syndrome, where patients tend to be older, PFS is an established, clinically relevant endpoint. In my opinion, it was important to see that POTELIGEO reduced the risk of disease progression versus vorinostat. As you can see in this Kaplan-Meier curve, POTELIGEO more than doubled median PFS versus vorinostat. As an investigator for the MAVORIC trial, I was pleased to see how early the POTELIGEO curve in blue started to separate from the gray vorinostat curve. You can see where patients taking POTELIGEO started to separate early in the course of treatment. Another important MAVORIC result is from a post-hoc analysis in which we looked at PFS by blood classification. POTELIGEO demonstrated longer PFS than vorinostat across all blood classifications. Interestingly, if we look at the results for the B1 and B2 blood classifications, we see that these patients had the biggest differences in PFS. Overall response rate, or ORR, is the percentage of patients in a clinical trial who achieve a complete response or partial response. In MAVORIC, ORR was a stringent endpoint. To qualify as a partial responder, patients had to achieve a 50% improvement in skin and in at least one other compartment. More so, they had no disease progression in any compartments. Interpreting a stringent endpoint like ORR in clinical practice can be challenging. ORR can help clinicians and patients interpret how effective a drug was in a clinical trial, but I try to help patients understand that overall response rate excludes patients with stable disease. We need to look at this in the context of an incurable disease, where stable disease or modest improvements is also very meaningful. ORR was a secondary endpoint of the MAVORIC trial. The overall response rate for POTELIGEO was 5 times greater than that of vorinostat. Not only that, a post-hoc analysis showed that the median time to response was shorter with POTELIGEO, which is an important consideration when treating patients with MF or Sézary syndrome. Time to response is an important endpoint that has a direct application to clinical practice. Mycosis fungoides and Sézary syndrome are diseases that can often manifest with considerable skin symptoms. We want to be able to see some relief from symptoms as soon as possible. Similarly, duration of response is an important endpoint in MF and Sézary syndrome clinical trials with application to clinical practice. Even if a drug has a high response rate, that result is meaningless if the response does not last. Time to response and duration of response are both very useful when I tell patients what to expect from a therapeutic agent. In MF and Sézary syndrome, it is important to consider overall time to response as well as the time to response in each disease compartment. In a post-hoc analysis, overall time to response was 3.3 months for POTELIGEO versus 5.1 months for vorinostat. Additionally, POTELIGEO had a median time to response of about 1 month in blood and 3 months in skin. Duration of response was a secondary endpoint of MAVORIC. Median duration of response was over 50% longer for POTELIGEO when compared to vorinostat. Patients with MF or Sézary syndrome can have a variety of skin manifestations of disease, and their patches and plaques can be difficult to measure. The Modified Severity Weighted Assessment Tool, or MSWAT, allows us to quantify changes in skin lesions in patients with MF or Sézary syndrome. We derive an MSWAT score by measuring each lesion as a percentage of total body surface area and multiplying it by a severity-weighted factor that depends on lesion type. MSWAT was another stringent endpoint in MAVORIC because patients had to achieve at least 50% improvement in MSWAT score to be considered a partial responder. MSWAT can give us a robust measure of drug efficacy in clinical trial, but MSWAT does have limitations. It does not take into account changes in the appearance of lesions, only their size. Additionally, it's rarely used in clinical practice as the tool requires experience and a trained eye and takes quite a bit of time to complete. In a post-hoc analysis of the overall clinical trial population, 43.5% treated with POTELIGEO had the best overall response of at least 50% change in MSWAT score compared with 22% of vorinostat-treated patients. When we look at results by blood classification, higher blood burden was associated with a greater reduction in skin involvement for POTELIGEO. 17.6% of patients with B2 blood classification treated with POTELIGEO had 100% improvement compared to only 3.2% of patients with B2 blood involvement classification treated with vorinostat. The most common adverse reactions reported in at least 20% of patients were rash, infusion-related reactions, fatigue, diarrhea, musculoskeletal pain, and upper respiratory tract infection. Other common adverse reactions reported in at least 10% of patients randomized to POTELIGEO included skin infection, pyrexia, nausea, edema, thrombocytopenia, headache, constipation, mucositis, anemia, cough, and hypertension. POTELIGEO was discontinued for adverse reaction in 18% of randomized patients, most often due to rash or drug eruption. In MF and Sézary syndrome, it is important to consider all disease compartments and evaluate a change in one compartment in the context of the full picture of the disease. When evaluating skin, I make a careful visual assessment of skin burden. If a patient experiences new or increased rash, I carefully consider whether the rash is evidence of disease progression or whether it is a serious drug eruption, which is a known side effect of POTELIGEO. I also monitor the amount of tumor cells in the blood because significant blood involvement has prognostic value that is independent of cutaneous or nodal involvement. Measurements of blood burden are particularly important when you observe a change in the amount of tumor cells in the blood because escalating levels of blood involvement are associated with a poorer prognosis. Lastly, I place high importance on patients' symptom burden when assessing response to any therapeutic agent. Improvement in certain symptoms like pruritus can be very meaningful for a patient with mycosis fungoides or Sézary syndrome.
Indication: POTELIGEO mogamulizumab-kpkc injection for intravenous infusion is indicated for the treatment of adult patients with relapsed or refractory mycosis fungoides, MF, or Sézary syndrome, SS, after at least one prior systemic therapy. Important safety information, warnings and precautions. Dermatologic toxicity. Monitor patients for rash throughout the course of treatment. For patients who experienced dermatologic toxicity in Trial 1, the median time to onset was 15 weeks, with 25% of cases occurring after 31 weeks. Interrupt poteligeo for moderate or severe rash, grades 2 or 3. Permanently discontinue poteligeo for life-threatening grade 4 rash or for any Stevens-Johnson syndrome (SJS) or toxic epidermal necrolysis. 10. Infusion reactions. Most infusion reactions occur during or shortly after the first infusion. Infusion reactions can also occur with subsequent infusions. Monitor patients closely for signs and symptoms of infusion reactions and interrupt the infusion for any grade reaction and treat promptly. Permanently discontinue poteligeo for any life-threatening grade 4 infusion reaction. Infections. Monitor patients for signs and symptoms of infection and treat promptly. Autoimmune complications. Interrupt or permanently discontinue poteligeo as appropriate for suspected immune-mediated adverse reactions. Consider the benefit-risk of poteligeo in patients with a history of autoimmune disease. Complications of allogeneic HSCT after poteligeo. Increased risk of transplant complications have been reported in patients who received allogeneic HSCT after poteligeo. Follow patients closely for early evidence of transplant-related complications. Adverse reactions. The most common adverse reactions reported in greater than or equal to 10% of patients with poteligeo in the clinical trial were rash, including drug eruption, 35%, infusion reaction, 33%, fatigue, 31%, diarrhea, 28%, drug eruption, 24%, upper respiratory tract infection, 22%, musculoskeletal pain, 22%, skin infection, 19%, pyrexia, 17%, edema, 16%, nausea, 16%, headache, 14%, thrombocytopenia, 14%, constipation, 13%, anemia, 12%, mucositis, 12%, cough, 11%, and hypertension, 10%. You are encouraged to report suspected adverse reactions to Kyowa Kirin Incorporated at 1-844-768-3544 or FDA at 1-800-FDA-1088 or fda.gov/medwatch.